Hello, I'm Dr. Sujana Chandrasekhar, and I'm the president of the American Otological Society.
Hello, I'm Nancy Young, Education Director of the American Otological Society.
We are really happy to welcome you to the AOS's second webinar. This one is on facial nerve monitoring, and we are doing so on behalf of the entire Council of the American Otological Society. The members of the council currently are from left to right on your screen: Dr. Nick Blevins, who is a member at large, Dr. William Slattery, who is the president-elect, Dr. Dennis Poe, who is a member at large, myself, I'm the president, Dr. David Friedland, who is the secretary-treasurer, Dr. Larry Lustig, who is the immediate past president, Dr. Marlon Hansen, who is the prior past president, and Dr. Nancy Young, who is the education coordinator. Our first AOS webinar was on September 13th, 2023, and it was on new technologies advancing otologic surgery. If you missed it or you'd like to watch it again, please go to the AOS YouTube channel using the link shown. Please type in where you're watching from and what you're interested in hearing about in the comments. You have to be signed into YouTube in order to share comments and ask questions. So please make sure you're doing so.
The 157th meeting of the AOS will be in person at COSM Friday and Saturday, May 17th and 18th. The guest of honor lecture will be given by Dr. Emma Stapleton of the United Kingdom, and the Sawmill Merchant lecture will be given by Dr. Rana Hertzano from NIDCD. We will also have 2 panels and 5 expert presentations, in addition to podium presentations and posters. The American Neurotology Society meeting will also be at COSM on Saturday and Sunday, May 18th and 19th, and we hope to see you in Chicago for both.
Yes, we certainly do. And the montage of pictures that came on before were from past meetings. So we hope we're having as much fun and as much education this May as we have had in the past. Let's introduce our webinar panel. We have Dr. Craig Buchman, who is professor and chair at Washington University in St. Louis, Missouri. Dr. Jack Kartush, who is at Michigan Ear Institute in Farmington Hills and has pioneered this technology, which clearly has revolutionized the way we perform ear surgery and the safety that our patients can expect from ear surgery. We have Dr. David Kaylie, who's professor and vice chair at Duke University in Durham, North Carolina. Welcome to all 3 of you.
Hi there.
Good to be here.
Thanks for having us.
We're really happy to get underway today. We have a lot to cover, and I know that we're going to be getting a lot of questions and comments from our viewers. People asked me why we chose facial nerve monitoring, and we chose it for a few reasons. One is it's a technological advance that has dramatically increased the safety of not just ear and lateral skull base surgery, but in fact of parotid surgery and thyroid surgery. Second, it has become so commonplace in just the last few decades that most of us don't really think about it, and therefore maybe we're not troubleshooting correctly or making sure we're monitoring exactly as well as we could. There are some recent changes with the introduction of a new type of monitor, which has led to some significant concerns. And many of our colleagues have reported some current concerns with how the monitor is functioning or not functioning, and we'd like to do a deeper dive into this. So we'd like to start. We have people watching from all over, and please write down in the chat where you're watching from. I have Mike Day watching from Forest Lake, Minnesota. Now I've got to put on my glasses, so the sham is over. We have Fernando Honoria watching from Los Angeles. Thank you for watching. I hope you find this interesting. Please let us know where you're watching from, and please put in questions and comments as we go along. Don't wait till the end so that we can answer as quickly as possible. We have Amy Banks watching from Wales. Hello, Amy. Glad you're up, late into the night. So I would like to start. Scott Shapiro from New Brunswick, New Jersey. Hamid Jalilian from Irvine, California. Sanjay Bansali's watching from Atlanta, Georgia. Vivian Zhu is watching from Houston, Texas. Let's see, Julia J. Louis is watching from Calgary, Alberta, Canada. We have Sushma Kunwar, who's watching. Nirmal Thapa from University of Florida Health in Jacksonville. We have Kristen, who's our fearless administrator who helps us put everything on, is watching from Florida. And yes, welcome attendees. So I'm going to just start by introducing Dr. who really does need no introduction to any of us. And what I'm going to say is that there are a number of commercially available facial nerve monitors that we use, but the overall principles are the same. We apply electrodes to the orbicularis oculi, which is usually blue for eyes, and orbicularis oris, which is usually red for lips. We then have 2 ground electrodes, which are green and white, and those are applied elsewhere. And then everything is connected to the patient interface, which is then connected to the monitor and tested, and we go. For thyroid surgery, similarly, a special tube is employed to make sure that the movements of the vocal cords are identified. But really, there's so much more to monitoring than these little pictures show. So Dr. Jack Kartush really has revolutionized otology, otolaryngology, skull-based surgery with the development of really easy to use facial nerve monitors and nerve monitors in the operating room. And I think you started this maybe 40, 50 years ago, Jack, and it has, I think that not only have you revolutionized it, but talking about it and making ourselves better at doing it is really of value to both the experienced otologic surgeon and the novice. So Dr. Kartush has been very generous and has shared a number of PDFs with us for those who would like to read more about this and really educate themselves. And they're housed on the American Otological Society website, and they are free. Thank you very much, Dr. Kartush. He also has a YouTube channel with a lot of information on it. For us tonight, he has prepared a really beautiful video that he'd like to share with us. So, Jack, I wonder if you'd like to introduce the video for us.
Thanks, Sujana. Really appreciate being here. First, a quick shout out to me mates down in Australia. Good on you, Zoran, for rounding up the crew down under. Because the audience is already familiar with the fundamentals of facial nerve monitoring, I'm going to focus on why monitoring can fail. I'd like to suggest today that you can immediately reduce your user errors if you adopt a monitoring protocol that was never part of your original training. So as Sujana has said, there's checklists that are on the AOS website. And if you go to YouTube, put my name in, you'll be able to see our teaching videos. So with that, Neil, let's take it away.
I'm Jack Kartush, and this is Facial Nerve Monitoring Pitfalls. As a student in 1977, it became clear that even the most experienced surgeon might injure the facial nerve. Anatomic knowledge was not enough to prevent injury. Therefore, while studying electromyography and neurosurgery in Stockholm, Sweden, I sketched out the idea for a simple EMG box to be brought into the operating room. It would be combined with stimulating instruments that would be used like a minesweeper for early detection. My inspiration was actually the game Operation that had electrified tweezers that would alarm if you got too close to the edge of the incision. It took years, but assisted by Dick Prass and Malcolm Graham, the first nerve integrity monitor was manufactured by Nicolay, purchased by Zomed, and then Zomed purchased by Medtronic. Since that time, numerous monitors have come to market, each with their own pros and cons. I want to recognize Herb Silverstein, one of the other pioneers in monitoring, He took a different route than I did, but he was an early advocate for monitoring all otologic operations.
Sorry for the audio. Jack, we need you to unmute yourself on your end so you can narrate the rest of the video. Jack, if you can unmute on your end. Thank you.
I'm not hearing audio for the video.
That's correct, Jack. You need to narrate from the rest of the way.
Oh, we're not hearing the audio?
That's correct, Jack. We need you to narrate. Thank you.
Okay, it looks like we have a glitch here. So this slide is talking about using stimulating dissectors so you have ongoing proof that the stimulation and recording are working properly. We want to use a minesweeper type of a paradigm. The further away you are from the nerve, the higher the current intensity should be. So as if you're looking for the general direction of the target. Conventional surgery is mostly listening for traumatic EMG activity, which is far suboptimal from what we would want to have.
So I like your minesweeper analogy, Jack, where if you're walking in with broken equipment and
Is
you
that
think
running,
you're
Neil?
monitoring, it's not going to be working. And I think Jack's point is that there can be user error and there can be device failure. And this endotracheal tube that has some monitoring wires on it had an extruding reinforcement wire that actually led to airway obstruction. So I think monitoring failure can be, like we said, user error or device error.
Well, right now, I'm not sure what the rest of the group is seeing. I'm just seeing this one slide, and the video's narration has stopped.
We are seeing the rest of the slides go through. Sujana is doing her best to narrate.
Okay, I'm not seeing the slides advance at all.
So I think, Jack and I went over this a while, and I think inadequate training for monitoring leads to a false sense of security where you think you're monitoring, but you're not. And I think when you read through Jack's material and the material that's on the American Otologic Society website, especially this article, Best Practices in Facial Nerve Monitoring, you really see how to do this systematically, how to use a checklist that you and the OR staff understand clearly so that you are very much aware of what you're doing. So when he's testified in malpractice trials, he's seen these common user errors that were identified during litigation, which is failure to...
The tap test. We tap at the end of the electrode. Using this artifact, which is not a true EMG response, it does tell us that there's connectivity between the electrode needles, the wire, and the monitoring device.
And here
I'm going to show you how we can now stimulate transcutaneously 5 milliamps.
No, there was narration throughout the entire video.
Nerve electrodes are functioning, and there's no muscle relaxant.
So Jack's talked about as well using stimulating instrument so that as you're working, as you know that you're closer to the facial nerve, you can use these stimulating dissectors without overstimulating the nerve and resulting in a unnecessary weakness later.
If I
But
touch
as you
anywhere on
get
soft
closer,
tissue, we should hear the warble tone, and that tells us that current is indeed flowing. If you touch anywhere on soft tissue and you do not hear the warble tone, then the stimulator or the monitor are not correctly set up and it cannot be relied on. Here we
Jack
can see the
talks
horizontal semicircular canal. The facial nerve should just be inferior. And here, at this level of stimulation, if there is no dehiscence, we ought to hear only the warble tone. However, if we now turn the stimulator up to 1.5, if there are some small dehiscences of the nerve, we might obtain a response. This now absolutely confirms that the monitor and the stimulator are working, and it also confirms that anesthesia has not inadvertently given muscle relaxants.
Could you at least hear the audio?
Yeah, thank you, Jack. I think even with a couple of glitches, we got a very nice sense of the importance of this. I'll ask you, as we're bringing our panelists on, I'll let you know that people are still telling us where they're watching. The University of Miami folks won't, the place won't let them go onto YouTube to log in. So I got a text from Mike Hoffer that they're all watching from Miami. Dr. Maura Cossetti is watching from New York City. Dr. Suicha Isara Daskul is watching from Chiang Mai, Thailand. Best dance channel ever. Varun Shetty is watching from Austin, Texas. All right, Varun. Dennis Bojrab, hi Dennis, is watching from Michigan. Somebody Jack knows very well. Anna Kim is watching from New York, New York. We have some Burning Pig watching from Salt Lake City, Utah. Okay. Catherine Kennedy is watching from Minneapolis, Minnesota. Darius Cohan is watching from New York City. And we have Doc Diego watching from Cali, Colombia. And you can keep seeing the names below. Jack, can I ask you, when you stimulate, like you were showing, so you talk about this minefield where you use less stimulation and then you focus it more as you're closer to the nerve. Is there a point where you are you possibly can cause weakness by overstimulating?
Well, I'll answer that. Let me just say that I was totally blacked out during the video presentation, so I did not see or hear it. Were you able to hear the live footage from the OR?
Yes. Yes,
could?
we were.
Okay. Regrettably, I missed all that. To answer your question regarding the safety, we know from a number of studies from John Leonetti and others that you can actually stimulate at 3 milliamps for an hour and have no injury. After an hour, you deplete some of the acetylcholine, then the EMG activity starts to go down, and a few hours later it comes up. So given the safe parameters that the NIM and almost all the other monitors use nowadays, they're using short square wave pulses. You should never be afraid to be using stimulation in the level of 1 or 2 milliamps. And of course, as soon as you get something at that level, there isn't any reason to be going to a lower level to get more selectivity.
So I have to say there are a couple of very cool comments coming in. Zoran is watching from Sydney, Australia. Rob Jackler says, nice presentation, Jack. Miriam Redleaf said, is a good job providing some impromptu narration, and she's ready to hear about the NIM Vital, and she's not the first person to comment on the NIM Vital. We had Arun Gadre, who is saying that the new Bluetooth-enabled patient interface is producing artifacts, and that Medtronic told them that the tap test was not necessary. I always do a tap test. Can I just have a show of hands of our panelists? Right?
Let me address that.
Mm-hmm.
The company has been working on trying to improve artifact rejection, which is a good thing. And it was believed that the artifact rejection was getting so good that doing the tap test would even be rejected. So I can tell you that the engineers flew up, we worked together for a few days, and unequivocally the tap test worked every time. And as again, I never saw my own video here, so I hope it showed the transcutaneous stimulation as well. So the tap test, and this is post hoc narration, but the tap test has always been extremely important to demonstrate that the electrodes, the wires are getting to the monitor. But only the transcutaneous stimulation, TCS, will assess the stimulator, the recording electrodes, and excluding neuromuscular blockade. Nothing else does that pre-incision. And one of my main points is if you take nothing else home from my discussion, start doing the transcutaneous stimulation. You take a stimulator, plug it into the box, non-sterile, start at 5 milliamps and work your way up. As soon as you get a response, you're done. So as a rule, it takes 10 or 20 seconds. And then, as hopefully the video showed, intraoperatively stimulate when you get soft tissue. That proves current flow. And then always try to get proximal facial nerve stimulation. Hopefully the video showed that if you're about to open the facial recess for cholesteatoma or cochlear implant, by stimulating around the corner in the epitympanum and getting a response, you know unequivocally stimulation works, recording works, that there is no lidocaine that has gone into the middle ear from a perf, and there is no peripheral neuromuscular blockade. So with that, you have definitive situation that everything is working, and you'll probably have less opportunities to have problems. And if you do, they're going to then be sequestered to a few more rare possibilities.
Thank you. We actually had a specific question asking you to explain the transcutaneous testing. So I think you answered that very well. I'll ask.
And I did today, just so everybody knows, in anticipation, put a separate little video on my YouTube channel specifically about TCS. So we thought that this would be a question, so you can take a look at that 3-minute video afterwards.
Terrific. For the panel, how many of you go through a checklist? How well versed are your anesthesiology colleagues and your nurses in what you're trying to do when you attach a facial nerve monitor? And maybe I'll start with Craig, Dr. Buchman.
Sure. Usually most of the people in the room are fairly familiar. We have a very sort of standard, protocol. We set up the machine in the same way. We put the electrodes in the same way. We always do the tap test, and I'll show some video later as to when we saw problems with the NIM Vital in doing these things.
And I think we all use some level of checklist, and I think we all communicate with the anesthesiology team about the need to avoid paralysis in particular. Nancy later on is going to talk to us a bit about lidocaine and trying to use epinephrine without lidocaine. Can I ask you, David, Dr. Kaylie, who does the monitoring for your chronic ear cases?
We do those ourselves. For a chronic ear, we set it up, we do the monitoring, we get to hear the actual signals as we're operating and feel that that's very, very safe. That's our method of doing it. And we always talk with the anesthesia residents or the CRNAs ahead of time, because we can have some very junior residents or some new CRNAs. And it's always good to tell them we'll be monitoring for these cases. So
I think that's one of the concerns that have been raised by many people that I've talked to, including people on this panel, is that because we're operating and also monitoring at the same time, we're really relying on auditory input. And I wonder, maybe Nancy, if you could talk to us about what happens when we don't get that auditory input, when we think we're monitoring and maybe we're not.
Well, that was what raised an experience like that is what raised my concern when I first used an Invital, and I'll go into that a little bit later. But I have to say, I think today's checklist that everyone now does in the OR has been real helpful for facial nerve monitoring, because we make sure anesthesia and everyone is on the same page about where we stand with paralysis. Another thing I think it's very important, which I think if you're doing Jack's checklist, you'll know, but not everybody, I think, follows every step that he outlined. But I think it's very important to make sure the darn volume on your facial nerve monitor is turned up. I've seen that error made. So if it can go wrong, it will.
Right. I have just stopped and said, "Hey, did somebody turn off the volume of my monitor?" Because I actually like that little brrr, that little white noise that comes. I'm going to talk about artifact versus actual EMG activity. And Jack, maybe we have this little slide that shows the difference. Can you tell us what we should be concerned about? And then Arun Gadre asks, says that the NIM Vital person said increase the threshold from 100 to 200 microvolts. What is the right threshold? And I think this is a good time to answer that question.
Yeah, if there seems to be a lot of noise, people will increase the threshold, but in most ORs, the 100 microvolt is fine. Now, looking at the tracings here, looking on the right side, you'll see that there is 2 biphasic responses that look very classic. And in this particular case, you can see they're using the masseter muscle as a control or a reference. Not everyone does that, but it is a good idea since that is controlled by the trigeminal nerve. On the left side, you'll see a couple slightly atypical blips, but at the same time, you see almost identical blips on the masseter channel. So this would unequivocally be consistent with artifact.
Thank you very much. I know there are more questions coming in, and some of them may be answered by our next presentation. So Dr. David Kaylie, who's at Duke University, served on the American Academy of Otolaryngology Head and Neck Surgery Task Force on intraoperative facial nerve monitoring. And I think you have a lot of really good information to share with us and our over 120 live viewers so far. Not to make you nervous or anything like that, David.
No problem. No problem. Thank you, Sujana. Thank you for having us. And hello to everybody out there. What I want to talk about is the rationale for intraoperative facial nerve monitoring. Next slide, please. We're going to start with talking about our the Academy guidelines, or the Academy Facial Nerve Monitoring Task Force, which had these members listed here. And our task was to look at what the current practices of facial nerve monitoring are, look at what into the educational requirements, what the education practices are for otolaryngologists and for residents, what some education gaps might be, and also to look at some reimbursement issues. The idea was to see, are there ways that we could try and get better reimbursement? Next slide. So we did literature search, and we're looking at all the literature written on this. We found that 75 to 95% of otolaryngologists, depending on the study, did have access to facial nerve monitoring. So a really high majority of people. And the consensus was it was most commonly used in mastoid surgery and much less commonly used in stapes surgery or straight up tympanoplasty without mastoidectomy. And the study showed that up to about half the people surveyed thought that facial nerve monitoring should be standard of care for all chronic ear surgeries. And we purposely use that standard of care because that does have a medical legal standing, and we wanted to see what people thought about that as a legal issue. Next slide. So one of the big questions is, does facial nerve monitoring reduce injury? And clearly this happens in skull-base surgery. We can use it to find and map the nerve in very large tumors where the nerve is draped over the tumor. It can alert us to potential injury, and it also gives us prognostic information. So we know how well the nerve stimulates at the end of the case will correlate with postoperative function. So it's really, really good information there. Anil Alwani did a cost effectiveness study, and this is a really rigorous economic modeling, and showed that the cost of monitoring facial nerve is justified compared to the cost of injury. So what that means is the cost of using the very minimal cost of doing facial nerve monitoring was far lower than what it costs to take care of a facial nerve injury. So it is clearly very cost effective, but it is not conclusive if it reduces injury in ear surgery. So the standard of care, whether it should be medical legally necessitated, is not clear. But it is clear that there's evidence of value. And in a best practice study, Lawani also showed that facial nerve monitoring is a value in chronic ear surgery. It's valuable for detecting an at-risk nerve, meaning if you're dissecting cholesteatoma and there could be a dehiscent nerve, it can really help you in that way. But it did not address reduction of injury in chronic ear surgery. Next slide, please. So we looked into who should be doing monitoring, and there's two camps. There's a separate neurophysiologist camp and a surgeon monitoring themselves. And there is a society, the American Clinical Neurophysiological Society, and they put out a position statement about intraoperative facial nerve monitoring and said that there needs to be direct supervision by a physician with training in nerve monitoring, and the physician should be licensed and or credentialed in intraoperative nerve monitoring. And they need to be either directly present in the OR or have remote monitoring where they have immediate access. And they should not monitor any more than 3 cases simultaneously. The counter argument is the benefits of surgeon monitoring, and we are there immediately. We are only doing 1 case at a time, so we're not simultaneously monitoring so that it has our complete attention. The auditory signals, as Sujana mentioned, is very important for us because as we're operating, we can also hear the auditory signals, which represent EMG activity, or the stimulation signals if we're using the stimulating probe. So we can correlate this directly to surgical events. If we're dissecting near the nerve and we hear a signal, we know exactly instantaneously what happened. And we also know that when we're stimulating potential structures, we know exactly what we're doing and we get an auditory feedback that's instant. Next slide. So the next part of the task force is we sent out a survey to practicing otolaryngologists and to otolaryngology program directors. And the program directors, 100% of the respondents said that the residents are exposed to facial nerve monitoring. So every residency has it. But they said that only 61% of the respondents said that there was formal education in intraoperative nerve monitoring. And for those that did, they didn't. 83% don't document this training. They just do it, but there's no documentation. So 72 and 83% don't assess for or document competency in their programs. And we also asked, I don't know how many of you out there knew this, but intraoperative nerve monitoring is an ABOTO core curriculum competency. It's mandated that at the end of residency that all residents should be competent in intraoperative nerve monitoring, but almost 80% of program directors didn't even know that was a requirement. So that is an education gap. In our survey of surgery practitioners, we found that a large majority use it in what we'd expect: mastoidectomies, atresia repairs, cochlear implants, and skull-based surgery. But a small minority routinely use it for stapy surgery or tympanoplasty. And of the respondents, 85% say they monitor themselves, 8% use an audiologist, only 3% use a monitoring service. So for chronic ear surgery, or it's really the surgeons who are doing the vast majority of the monitoring. Next slide. Then we looked at reimbursement, and this was a big issue. And in the survey, we found that 64% of respondents don't even bother billing because we know we're not getting paid. And of those that do bill, they said only 4% said that they're reimbursed by Medicare, and 20% said they're reimbursed by private insurance. So it's not a commonly done thing. And the position statement by the neurophysiology team really has made it hard for us to get billing. Next slide. Oh, I believe that's it. So basically, the task force really gave us good understanding of what the practices are, and it really pointed out that there is a pretty significant education gap among residents about how to document training.
Yeah, and I think this is really very important. This is something that's very important for patient safety. As you said, our board, it's a core curriculum, part of our training. So I think paying more attention, I think maybe program directors can use this webinar and Jack's videos to really train up their residents and their fellows to make sure it's working. As we bring the panelists back, thank you so much, David. That was really excellent. And I know how much work that task force was. So thank you again very much. We have Mike Hoa, who is watching from Georgetown. Again, he can't log into the YouTube, so he just texted me. If you can't log in and you want to ask a question and you know me, go ahead and text me and I will put your question up. We have two interesting questions up. I really wish I knew who Burning Pig was, but there's a check electrode setting on the facial nerve monitor. Is that more reliable, or is the tap test more reliable, is their question. And I think that made more sense when we didn't have the paired electrodes. We had the single electrodes and you couldn't let them touch each other. So you had to make sure they were the right distance apart. Am I dating myself at this point? And then Jacques Herzog is asking 2-channel or 4-channel. So I'm going to start with Jack on these questions.
Number one, the tap test is additional complementary information to impedance. And just like Suj has said, if you're using single electrodes, if you happen to put the tips touching together, that could be an issue. That's rarely a problem. But again, what happens is with an impedance test, you'll know that the impedance is usually within under 5K ohm. But with the tap test, you're also able to then hear the response going to the NIM, and you're also confirming that the volume is up to a proper level. When the NIMs first came out, they booted up at 0, and so that was more of an issue. The NIMs now boot up at a setting of 5. And I would like to say, obviously, not everyone uses a NIM. And one of the tech improvements for the NIM very early on is the ability to do two things: stop the stimulus artifact from being confused with the response, and also to be able to block out noise, let's say from cautery. So when we first started this at University of Michigan, we had an audiologist that came in the room with us, and he or she would have to sit there with the volume control, and as soon as they saw the surgeon pick up a cautery, they had to turn the volume down so you wouldn't get blasted. I had suggested this to other competing companies because I think it's something they should all have, but I believe most other companies do not have this automatic cautery suppression and turning down the volume. So if you have somebody there that is running herd on the volume control, it's also very important that they don't forget to turn it back up.
Right, and we also use that that muting device, right? So if you're going to be using electrocautery, there's a way to mute the device, not completely, but for when you are using the electrocautery. And you must be aware that the facial nerve monitor is in fact muted and you won't get feedback from it when you're using the electrocautery because of the way it's designed to avoid artifact and stressful blipping and bleeping. David, you had mentioned that most people use facial nerve monitoring for mastoidectomy and cochlear implant and atresia surgery. And Bill Slattery and Jack Kartush did a very nice study surveying about 200 otologists, neurotologists, and they found, and we have a little visual of this, they found that you can see in the blue, the vast majority of people use it for mastoidectomy and cochlear implant, and about half of people use it for tympanoplasty and possibly for a little bit more complicated tympanoplasty. So I think we definitely are seeing the adoption and the judicious use of this in a way to help patients. But I want to move on because we have a couple of questions that are really interesting. Nancy, one, I'm very grateful for our friendship, and I'm also very grateful that we serve on AOS Council together, because you very early alerted the council, and in subsequent, the rundown was the AOS, the ANS, the American Academy of Otolaryngology Head and Neck Surgery were all alerted to some problems that you identified quite early on. And unfortunately, we always find these concerns by accident. So can you talk to us a little bit about that?
I'd be glad to, Sujana. Most otolaryngologists, as we know, use Medtronic's NIM system. I mean, they dominate the market, even though there are others available. And I'd like to talk about my experience, but also highlighting some of the others' experience so far with the new NIM, which is called the NIM 4.0, and it's marketed as the NIM Vital. Okay, so at my hospital, we had a whole series of these new NIM Vitals replacing the earlier generation NIM 3, and one of them was quite frankly a dud. And what it would do is it would intermittently stop monitoring, and I realized that when it stopped monitoring, this is what you would see on the screen. You would see this visual saying there's a problem, but I didn't hear an auditory alarm. So this was very concerning to me. I spent quite a bit of time talking to Medtronic's technical support. And what I learned was that if the monitor were to stop monitoring, I'm not saying shut off, the monitor itself is live, you know, the visual screen. But if it stops monitoring, you will not hear any type of alarm. You will hear what Medtronic calls an alert, which is a beep once every 30 seconds. Which is not very alarming. It's not even very alerting. And for that reason, I communicated with the AOS Council, and they were equally concerned. And Sujana, you really took the leadership role and immediately got Jim Denaney involved. And then we started having meetings that concluded ANS leadership and Craig Buchman representing the Hearing and Balance Committee. And we had a good number of meetings over time. But so far, I can tell you, I think I can speak for everyone who's been involved, that we all remain concerned that design improvement is needed, and that additional education of surgeons alone is not enough to optimize patient safety. We need design improvement in addition to surgeon education. I'd also like to point out there's an important difference that everyone needs to be aware of in terms of this monitor's sensitivity to mechanical pressure. And this is something that I've noted myself, Sujana has noted, and others have commented to us. So when you have a nerve that's partially or fully exposed, for instance, in the facial recess, and you tap on it with a gimmick, you do not get a response. And this is a very different than the earlier generation NIM, and that can be very misleading to the surgeon. And I have found it helpful to I need to use the stimulator if there's a question as to whether a small area of the facial nerve has been unroofed. Don't rely on any sort of nerve tap test. I'd also like to highlight another important point during our discussions with the manufacturer, and that is that the engineers do not recommend that you use the NIM Vital on its wireless mode, which is dependent on
Bluetooth, right?
On Bluetooth for cases that are more than 4 hours, because it runs on batteries, and the batteries can run out, and over the life of this machine, the batteries are going to run out over a shorter period of time.
So thank you. I think this really highlights some of the issues that we found and we didn't expect to find. And you know, when as David was saying, if we're monitoring our own cases and we're expecting to hear an alert, and all it is a little blip every 30 seconds, and we turn and we see this on the screen, that's a real issue. What happened in the course of events is that our colleague, Dr. Buchman, decided to do things very scientifically, as he is wont to do. And Craig did a head-to-head comparison, really trying to figure out where the problem might lie and what we can possibly do to reestablish the safety that we expect. So Craig, take it away.
Thanks, Sujana, and thanks for the invitation to be here. So I'm just going to talk about our experience that we've had at WashU. Listed there are a variety of the people that have worked on this. So this has not all been me. Next slide. So as you all know, many of us have used the NIM3 for many, many years with a lot of success. When we saw issues with that particular device, it was mostly setup related. You know, either the electrodes were displaced or in an awkward position, partially in. Maybe the patient interface might fall off the side of the table, as many of you have seen, and pull the electrodes out, occasional artifacts, but not a lot. And we're generally very easy to troubleshoot. Many of us saw issues during COVID with those electrodes not being available. The incrementing probe did have problems. And so the PRAS probe, which you all know is a fixed stimulus, the incrementing probe had more problems. And then the endotracheal tube, which our head and neck colleagues deal with all the time, has had a long history of issues. But for the most part, NIM 3.0 has been a very solid device. Next slide. The NIM 4 or the NIM Vital, we purchased in April of 2022 as we opened a surgery center. There was 15 machines that displaced all of our NIM 3s. There was immediately a recall in June of 22 due to some patient interface issues and software problems. And so we expected some glitches as we were getting started. So you know, we didn't think that this was necessarily going to be sort of a long haul. Next slide. What we started to see from very early on is sounds generated by the machine when you weren't near the nerve. And those are basically referred to as false alerts or artifacts, to be differentiated from false positives, which are generally stimulation related. So these are sort of random false noises from the machine that you'd think of as artifact. They can sound like trains. That can be single in nature, multiple in nature. That can happen with the wound open, closed, chronic ear surgery, skull-based surgery. We would reboot the machine when we heard some of this without really any change. You'd turn it off. When it boots back up, the sound would still be there. It could happen in the hardwired mode or the Bluetooth patient interface mode, as was just described. Checking the electrodes and moving the patient interface generally wouldn't resolve those. And it was quite variable from OR to OR, surgeon to surgeon, case to case. And it also wasn't necessarily responsive to even temporary giving some neuromuscular blockade. Next slide, thanks. Yeah, so and then the false stimulation was also an issue. And just to be clear on the terminology, the false negative is when you see a normal nerve and contact with current delivery, elicits no response. That's what we would refer to as a false negative. We oftentimes would see an initial positive stimulation first, and then followed by a negative, or we might see a false negative right from the beginning. Oftentimes, as Nancy showed, there might be an artifact rejection on the screen as well. And so, and then the most troubling one, which was, I think, a lack of training, is they had built in a refractory period to the stimulator. And so you would put the stimulator on a nerve, it would give you initial pop. And then when you would pick it up and then put the probe back down on the nerve, it would not deliver any sound proving that it was stimulating. And there would be a 4 to 5 seconds of refractory period before it would start. So if you were trying to track a nerve with the stimulator, it wouldn't work. So those are a whole variety of false negative issues that were super frustrating. The false positives were actually less common. That would be when you see a normal nerve and remote contact, say on the temporalis or somewhere else, gives a positive response. Again, sort of in the background of a bunch of artifact sound, this was a big issue. Next slide. So these are a couple of examples of some of the setup artifact that we heard. Neil, can you run the first video? And then you can go to the second one.
The patient's not late? No.
Thank you. And so you can see this type of artifact was present literally right from the beginning when the patient was put to sleep and the device was turned on. Super frustrating. And sometimes we'd also see warnings, as I showed there on the right side. So to the next slide, please. And the next one after that. So, so what we did is we did an experiment actually to try and better understand what was going on. We set up in parallel the NIM Vital, and then we also set up an electrophysiology team that was monitoring at the same time. And while there were false alerts going on, like I just showed you on the previous slide, we asked the neurophysiology team what they were seeing, and they were seeing none of the artifact. So there was some concern that actually the artifact, I think as Dr. Gadre mentioned, was actually coming from internal to the machine. In the early days, we switched out actually 10 patient interfaces because we thought that was a part of the problem. And I think Dr. Kartush and Dr. Babu have recently done some work at Michigan Ear where they were able to show that the patient interface is indeed generating the artifact. So that's probably one of the major issues with this particular device. You should know that there's been a lot of software updates to try and address this. Next. Back one, forward one more. There you go. So what we did is we obviously have been in close contact with the Medtronic representatives, both the reps in the room as well as engineering have been present for many of our cases. In the early days, there were software updates that were occurring all the time. In fact, we wouldn't even know how often they were updating the software, which was pretty frustrating from case to case, not knowing what's going on. Our reps were reporting most of this up to the engineering in the company with videos and screenshots, as you saw. And many of the reps actually, as you all mentioned, actually were aware and were talking amongst themselves about some of the issues that were going on. What we ultimately did, because we were having such problems, is we actually asked the company to change all the NIM Vitals out to NIM 3.0 Neuros. The difference between that and the 3.0 that we always use was that it has 8 channels instead of the usual 4. But we saw literally total resolution of those issues. Obviously, I've had a lot of conversations with the group from all of our societies, and we were concerned that this is an issue around the world. We've spoken with the FDA, and we actually also spoke with Medtronic leadership, and we feel like they're starting to make some slow changes. Next. Well, I didn't really talk about the MAUDE database, but I think we have a slide here.
Right, and I'd like to bring all the panelists
sure.
on while you talk about the MAUDE database,
Sure.
because I think this is really important. It's something, I didn't really know how to report anything, right?
Yeah, sure.
So, one, I'd like to say, Jack, that Varun Shetty from Austin wrote in that he loved your video, and he actually pre-watched your video that you had posted earlier to prepare for this and highly recommends it to everyone. Maybe we can put up the how to report slide, and Craig, you can talk us through this.
Sure. So importantly, for everyone dealing with any devices, and I've learned most of this actually from the cochlear implant world, as many of us have struggled with device failures over many years. There's a FDA site and an FDA run database called the MAUDE database, the Manufacturing User Facility Device Experience. And so whenever any of us has a problem with a device, whether it's just a glitch or whether it seems like something more serious, you should obviously report to the representative from the company, and it's their job to run that up through the usual pipeline. But you should also go on to the MAUDE database and fill out a report. It can be very, very simple. It can just be a matter of sentences, but importantly, the manufacturers are required to respond to those reports. So as we were starting to have problems, we decided to go look at the MAUDE database and see what we saw. Can you go to the next slide? I think, yeah. So we looked up the NIM Vital 4.0, and this gives a sense of, some of the reports that are out there. And it says many of the things that I think we just reported, but importantly, you see that there are some patients that have had permanent injury from, during cases. Now, as Jack pointed out and many others have, there are obviously technical issues that can occur with the device. There could be technical issues related to our use of the device. And so it's important that we all be exceedingly well trained, but recognize that we believe, and I think the company recognizes, that there are some improvements that need to happen in the current device to make it better for usage. So thanks.
Thank you so much, Craig. We still have 120 plus people watching, and we're really grateful. If it's okay with you guys, we're going to go about 10 minutes over time because there's a lot of interesting questions coming in, and I'd really like to get to them. before getting to them, I'd actually like to have Nancy talk to us about what happens if in children, and then about injecting lidocaine with epinephrine versus epinephrine alone, and how we should manage that in our cases. So, Nancy, do you mind taking it away for us?
My pleasure, Sujana. So use of commercially available lidocaine with epinephrine for our canal and post-auricular injections is very common. However, as we know, lidocaine can interfere with monitoring, and this is especially true in young children for whom the nerve is less likely to be encased in a bony channel. And in young children, the vertical segment is more superficial than the mastoid. However, having the OR staff mix the weight-based concentration of epinephrine causes increased risk of a dosing error, which can cause potentially very serious complications. So, we don't want to do something to be safe in one area only to cause more complications in another, right? So to improve safety in our children's hospital, it actually was mandated that the pharmacy, that the nurses are not allowed to mix epinephrine for us for injection, and that the hospital pharmacy must custom make this for us and have it, so that it's available for whoever needs it in the operating room. And it's really worked beautifully. But unfortunately, the availability of a pharmacy to do this is not readily available at all medical centers and outpatient surgery centers. I think it's really going to take planning and advocacy on the part of surgeons to make this available so that we can have this as an additional safety measure for our patients.
Yeah, I think I ran into that question when I asked at a major hospital, and of all the inpatient pharmacists, one or two seemed comfortable making this. And so I think this does require some planning and some thought and some understanding by all parties concerned about what is the question. So like I said, we're going to keep going. So we have 12 more minutes. Send in your comments, send in your questions. I'd like to bring the whole panel on. And there are a couple of issues. One is Jay Gantz is watching from Portland, Oregon. David Mouton is watching from Broussard, Louisiana. So I kind of love the way David's last name and his town sound. It's a really good sound. Arun Gadre asks, if the pressure, tapping on an exposed facial nerve with a gimmick, let's say, doesn't result in a response, what happens with the drill? And I think one of those terrible outcomes that was reported had to do with the shaft of the burr in the shaft of the drill in the facial recess, while the burr was drilling at a partially ossified cochlea. So with no alert by the monitor. And I don't know, Nancy, if you have some familiarity with that case.
I would like to speak to this, and I'd like to get Jack's input too. So my training in facial nerve monitoring going back 30 years is that if you heat the facial nerve with the turning of the shaft of the burr, heat is not going to set off the monitor. It's electrical stimulation does, and mechanical tapping does, but heat is not something you're going to get a warning about. Jack, am I right or am I wrong?
Well, I think you took the course 30 years ago, Nancy.
I did. Your course.
So it is possible for heat to cause some changes, but it is a gradual increase in the baseline, which is often subtle. And unless you're looking for it, you're not going to see it. It is not going to be a big compound muscle action.
But you're not going to hear beep, beep, beep if it's just.
Correct. So unless you turn down your threshold to 30 microvolts instead of 100 or something, then at that point, the threshold might come up to the point that you see something. But as a rule, no, you can't count on it. Now, conversely, sometimes if the shaft of the drill is somewhat bouncing on the nerve, then you can get some what I call drill potentials, and then they're synchronized with what you're doing. So as a surgeon, you start hearing some little beeps, or If you are assisted by your technologist or neurophysiologist, he or she might be saying, well, I see some little subthreshold things here. You as a surgeon know what you're doing. You might say, all right, maybe my drill shaft is causing some of this. And then I would say too, I've done 40 years of medical legal stuff, and I've tried to benefit everyone as much as I can, but I've seen the most experienced people run into pitfalls now and then. And I wish I saw my video tonight. I didn't see it, but one of the things that's important is that proximal stimulation. And again, I don't think that this is common knowledge, but I hope it showed in the video that if you take a stimulating needle, you can reach around the horizontal canal, get a response, and now you know there's no lidocaine, there's no neuromuscular blockade, everything is working. And so at that point, if you're drilling in the facial recess and you do get enough of the trauma to evoke a CMAP, compound muscle action potential, it should unequivocally show that. Now, playing the devil's advocate, which I think is always a good idea, is that if a company gets better and better artifact projection, we always have to be careful. Are we starting to reject not just the noise, but the signal? And this is the type of thing that takes a lot of work to investigate. And as Craig was talking about, we also need a common knowledge. As frustrating as it is for the neurologist, the neurophysiologist, the surgeon in the operating room, if they say, quote, beep, 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 everything is beeping, and they call the 1-800 number, then the tech in customer support is saying, all right, well, the surgeon is saying that this is a false positive. But as Craig's already alluded to, if you're not stimulating, that's not a false positive. That's noise artifact. And so we need a common knowledge. What I'm suggesting is anytime there is a glitch, that there be a way to report it, such as a web link, and it immediately asks you what's happening with these 10 things, what unit are you using, and then the customer support also looks at the same thing. And now you've got something to go by. The other thing that I think I alluded to in my video is that there still is a fair amount of surgeons who monitor on their own. When I first designed the NIM in 1980, we intentionally did not build a printer or a RAM memory. Because I was seeing fetal monitor lawsuits, and they were saying, well, yeah, I think at 2 o'clock in the morning, this little beep meant that there was fetal distress. And there was always misreading. So now, obviously, for years, we had that. Conversely, it's my understanding that most surgeons who self-monitor don't fill out a report, particularly because they're no longer getting billed. They're no longer getting reimbursed for it, which is a whole other conversation that I can address. But suffice it to say, one of the suggestions I'm making is that if you follow my guidelines, the NIM and other devices should lead you along the path. So you boot up the machine, it does a impedance test. You tap it, and now it says, tap test correct. You now do transcutaneous stimulation, success, and it goes into the RAM. Now, even if you choose not to report on it, a day or 3 months later, when you're doing a mod report, you've got that objective information that will benefit you and the company. But right now, it's all garbage in and garbage out. So these are the changes that I'm proposing.
So I think these are really very helpful. I'm just going to read off some comments and some questions because I think they're very pertinent. Hamed Sajadi says he's had 2 instances where the pairing between the interface and the unit suddenly just stopped, and that the Bluetooth is unreliable. And I have to say, I am very, very old-fashioned, and I have never used the Bluetooth. I don't understand why I would use it wireless. I mean, who am I that I need a wireless thing when everything interferes? Go ahead, Nancy.
I just want to interrupt. I think that you're not old-fashioned. You're smart, okay? So there's someone asked, Arun Gadra has asked a very good question. He said, can we eliminate these problems if we hardwire it instead of using it Bluetooth? No, you cannot. Okay, because I have always used it hardwired, and I know Dr. Buchman in his testing has been using it hardwired. Sujana's been using hardwired, and we have issues. Maybe we'd have more issues if we weren't, but that does not solve our concerns.
And you know, it's low-lying fruit. The first thing that you hear about is it's got to be Bluetooth. And so it's not unreasonable. But the panelists are saying exactly what we found. And I'm grateful to my partner, Dr. Sai Babu, who took a few days, you know, with us to do all this different testing to give us information. And the company isn't ready to come up with a full report, but as Craig has already indicated, right off the bat, you know, we found some things with the PI, the patient interface. We found some things with the software. So we know that improvements are unequivocally coming, and it's having a bilateral conversation with the manufacturers, no matter who they are. Remember, with complex things, whether they're Boeing airplanes or nerve monitors, the more features, the more potential bugs. And so there always has to be ongoing conversations with the users and the manufacturers.
You know, Jay Rubenstein writes as CIAP 2023, but he writes a really good comment. He says, "Listen, we saw a lot of these problems in the beginning, and he is giving you know, some feedback that we're not seeing as many of those problems now." I have to tell you, I recently did a case where the patient became very light under anesthesia, and every part of their body moved, and I can imagine that their face moved, and my monitor, which was hardwired, stayed silent. So what kind of an error was that, Craig?
Yeah, that's a really good question.
That was the error that took away a couple of years of my life.
Well, you know, I think you need to be thinking that the system is not working properly. I mean, what do you want to call that? I mean, that's a good question. It's sort of a false non-response, but you're making the assumption, obviously, that the patient's face is moving. But suffice to say is, I mean, obviously you need to start all the way back from the beginning and think of each of the things, you know, think about electrodes, think about the patient interface, think about the box, making sure, as Nancy, you know, pointed out, that it's not muting. Those are all really, really important points. I just want to point out, actually, I had a recent conversation with the company and with Medtronic, and I, you know, I think they hear us, not just me. I think they hear all of us. My sense is the wheels are turning, which is good. It's taken a fair amount to get the wheels turning, but they hear us. And I think, as Jay points out, he said he saw a lot of the problems with the NIM Vital early on, and then they're not seeing as many problems now. I think, you know, a lot of the updates that happen, none of us on this panel or anyone in the YouTube, we have no idea how often they're updating these machines. They bring in a small stick drive, they plug it into one of the back of your machines. The next thing you know, there's a software update and we're not even aware of it. So my sense is that they're probably getting this under control slowly but surely. The filter issue that Jack mentioned, I think, is a real issue. That's an issue that is different between head and neck surgery and neurotology. And so I think that we still have some things to solve in that space as well.
I want to ask a very simplistic question. Do you guys, in the old days, when, you know, we didn't really believe, Jack, that we could monitor the facial nerve, we kept the face exposed for all ear cases. And somebody, either a junior resident or the scrub tech or somebody, had to watch the face. Do you guys do that now? Do you expose the face so that somebody can visually monitor it? And I'm going to start with David. During your ear cases?
No, I don't. When I was a fellow, that was done. And that was a while ago, maybe a good while ago, but no, we do not now.
Nancy?
Have not been doing that.
Craig and Jack?
No, so on parotids, but on intratemporal mastoid, no. And in all the cases that I'd heard early on, like at House, etc., by the time the nurse is able to palpate the twitch, the nerve is either transected or close to it.
I did speak to some other senior otologists who still keep the face out, I think, as a sort of belt and suspenders to try to, you know, ensure. And I think it's a testament to us trying to be as safe as possible for our patients. Elizabeth Toe, who is the president of the American Neurotology Society, is watching, and there's a really lively conversation going on in the comments about the various different types of NIM devices and other facial nerve monitors that are available. And I think that is definitely a discussion for a different time. But I want to thank our panelists very much for having spent this now hour and about 10 minutes, 11 minutes with us. I think we all learned a great deal. I really do encourage people to go back and read the materials that are in PDF format on the American Otological Society.org homepage, and they are open to everybody. You don't have to be a member of the AOS to access them. I highly recommend that you go to Dr. Kartush's YouTube page and look at his videos. And I want to thank you on behalf of the American Otological Society for joining us today. And I'm going to leave it to Nancy to issue another invitation to join us in Chicago live.
Well, we are certainly looking forward to seeing every one of you in person at the AOS meeting in my hometown of Chicago in May.
Great. So thank you again, Dr. Craig Buchman, Dr. Jack Kartush, Dr. David Kaylie, Dr. Nancy Young, to our wonderful audience, to our friends and our to-be friends who have joined in today. Thank you so much.
Sujana, may I just say,
Yeah, of course.
I'm disappointed that the video didn't come through the way it was supposed to. I will upload a full one on my YouTube page in the next day or so.
Excellent. And I know that you've talked a lot about electrified instruments. It was on the video as well. And I think that's something that people should really pay attention to.
Thank you.
Thank you again so much, everybody.
Take care.
Cheers.
Ciao.